Hello, I'm Dr. Roger Henderson, and I'm one of the GPnotebook study group presenters. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'll be discussing myasthenia gravis, and the challenge with this condition isn't so much recognizing the textbook presentation, but in picking up the quieter, early signs or managing the complications and treatment decisions that come later. So myasthenia gravis is manifest from infancy to old age, and more women than men are affected, with the incidence being significantly higher in black women, particularly in America. Women usually present under the age of 40, whereas men typically develop symptoms later, with a median age of onset in the 7th decade. But as we all know, it remains an uncommon disease with a worldwide prevalence estimated at 12 people per 100,000 of the population. Now, fundamentally, myasthenia gravis, or MG, is an organ-specific, antibody-mediated autoimmune disease, where antibodies are present at the neuromuscular junction, the site of pathology. Up to 90% of patients have detectable antibodies against the nicotinic acetylcholine receptor on the postsynaptic muscle membrane at the neuromuscular junction. Now, there are no specific risk factors for the development of myasthenia other than genetics and the presence of other autoimmune diseases in the patient or family members. I do think it might help to visualize the neuromuscular junction as a finely tuned communication system. So, a nerve impulse arrives at the presynaptic terminal, acetylcholine is released into the synaptic cleft, and it binds to receptors on the muscle end plate, triggering contraction. Now, in myasthenia gravis, that communication breaks down, not because the nerve isn't firing or because the muscle is intrinsically diseased, but because the interface between them is disrupted by an autoimmune process. Now, as I've mentioned, in the majority of patients, antibodies are directed against the acetylcholine receptor, and these antibodies do three main things. Firstly, they physically block the receptor. Second, they accelerate receptor degradation by cross-linking them and promoting internalization. And thirdly, and this is really the key here, they activate the complement cascade, which damages the postsynaptic membrane structurally. So the end result is not just fewer receptors, but a simplified postsynaptic architecture. Now, approximately 3 to 7% of patients have antibodies directed against muscle-specific tyrosine kinase, or MuSK. And when we look at MuSK-positive disease, the mechanism is actually different. These antibodies don't activate complement, but instead they interfere with the signaling pathways that organize the neuromuscular junction, specifically the clustering of acetylcholine receptors. Now, clinically, this distinction matters because these patients often behave differently. They may have more prominent bulbar and respiratory involvement and respond less well to standard symptomatic therapies. And so from this, you can see that myasthenia gravis isn't a single disease as such, but more of a spectrum. Now, the thymus plays a fascinating and still not completely understood role here. In many patients, particularly those with acetylcholine receptor antibodies, the thymus is abnormal. It may be hyperplastic, with germinal centers actively producing immune cells, or it may contain a thymoma. So why does that matter clinically? Well, it's because the thymus appears to act as a source of autoantibody production, and that's why removing it in a thymectomy can improve outcomes even in patients without a tumour. And this means it's one of the very few autoimmune diseases where surgery can meaningfully alter the course of the disease. Now, if we now look at clinical presentation, this is where pattern recognition becomes critical, because as we all know, patients rarely walk into our consultation room saying, "I have fatigable weakness." Instead, they describe functional difficulties. So, a patient might say their eyelids feel heavy by the end of the day, or that they need to rest while they're eating because chewing becomes tiring. They might report slurred speech after having a prolonged conversation, or difficulty holding their head up in the evening. But in practice, ocular symptoms are the most common starting point, and ptosis and diplopia occur early in the majority of patients. The ptosis can be unilateral or bilateral and often fluctuates, and the diplopia is variable and may change depending on the direction of gaze. Now, one subtle clue here is variability. So if the pattern of eye movement weakness doesn't fit a single cranial nerve, then think neuromuscular junction. Between 50 and 60% of patients who present with purely ocular symptoms will progress to develop generalized MG, and the vast majority will do so within the first 1 to 2 years. Now, as the disease generalizes, bulbar symptoms become particularly important. Dysphagia and dysarthria aren't just inconvenient, they carry a risk of aspiration, and patients may compensate by eating slowly or avoiding certain foods. So we have to ask about this directly. Any limb weakness tends to be proximal, and patients might struggle with activities like climbing stairs or lifting objects overhead. Examination of the limbs shows proximal muscle weakness with fatigue, and arm abduction time can be checked by asking patients to simply hold their arms outstretched. Healthy people can typically hold their arms up for more than 3 minutes. There shouldn't be any evident muscle wasting, and unlike many other neurological conditions, reflexes remain intact, and there are no sensory deficits. So that combination of motor weakness without any sensory loss is a really useful diagnostic clue in my experience. One of the most dangerous aspects of myasthenia gravis is the potential for a myasthenic crisis. And this is when respiratory muscles become too weak to maintain adequate ventilation, and it can develop gradually or quite rapidly, often triggered by infection, surgery, or certain medications. So from a practical standpoint, any patient with known or suspected myasthenia who presents to you with breathlessness, difficulty speaking in full sentences, or signs of bulbar weakness should raise concern. Serial measurements of forced vital capacity, FVC, should be taken, and early involvement of critical care is essential in these patients. If we look at diagnosis now, this is an area where clinical judgment and investigations need to work together, and antibody testing is highly informative. Acetylcholine receptor antibodies are very specific, and a positive result in the right clinical context is essentially diagnostic, but unfortunately not all patients are positive. And this is where muscle-specific tyrosine kinase, or MuSK, and LRP4 antibodies come in. So if the standard test for AChR antibodies is negative, then we should proceed with MuSK antibody serological testing. and MuSK antibodies are detected in up to 70% of patients with generalized MG who are seronegative for AChR antibodies. Now, although LRP4 antibody testing isn't widely available yet, it can be really clinically helpful if it is. If serological testing is unremarkable, or if there are atypical clinical features, then electrophysiological testing should be performed, and repetitive nerve stimulation demonstrates a decremental response, reflecting the failure of neuromuscular transmission with repeated activity. And single fiber EMG is even more sensitive and can detect abnormalities before they're clinically obvious. Imaging is also crucial, particularly to assess the thymus. A CT chest scan should be performed for all newly diagnosed patients to detect any thymoma, which occurs in about 15% of patients with MG, or thymic hyperplasia, which occurs in about 75%. Looking at treatment next, this is where management becomes highly individualized, and symptomatic treatment with pyridostigmine is usually the first step here. This works by inhibiting acetylcholinesterase, thereby increasing the availability of acetylcholine, and patients often experience a noticeable improvement. But it doesn't alter the underlying autoimmune process. So this is where immunosuppression comes in. Corticosteroids can be very effective in patients in whom pyridostigmine monotherapy isn't effective, but they come with significant potential side effects, especially with long-term use. And in addition, some patients may actually experience worsening of their symptoms, including the risk of precipitating a myasthenic crisis if corticosteroids are started at a high dose. So we often introduce steroid-sparing agents, such as azathioprine, which is recommended as the first-line immunosuppressive treatment for myasthenia based on its effectiveness and tolerability. Now, the challenge for all of us here is that these medications take time to work, sometimes even months, so bridging strategies are often needed. For patients with severe disease or those in crisis, rapid therapies include intravenous immunoglobulin or plasmapheresis, and these treatments reduce circulating antibodies and can produce relatively quick improvement. Thymectomy may be considered early in the disease for patients aged between 18 and 50 to minimize the need for immunosuppressants, including long-term corticosteroids. And thymectomy should be strongly considered for all patients with generalized myasthenia in whom a trial of immunosuppressants is ineffective or produces intolerable adverse effects. And evidence does suggest it can improve long-term outcomes and reduce the need for ongoing immunosuppression. As we know, any treatment isn't without risk, and long-term steroid use can lead to osteoporosis, diabetes, hypertension, and other complications. Immunosuppressive therapies increase the risk of infections and, over time, even certain malignancies. So managing MG is always a balance between controlling the disease and minimizing treatment-related harm. There's also the issue of a cholinergic crisis, which can occur if acetylcholinesterase inhibitors are overused. And clinically, this can mimic worsening myasthenia. But the presence of muscarinic symptoms such as excessive salivation, diarrhea, and bradycardia can help to distinguish it. I think it's worth very briefly touching on differential diagnoses here because several conditions can look similar. So, for example, Lambert-Eaton syndrome also causes weakness, but it typically improves with repeated use rather than worsening. Botulism can present with descending paralysis and cranial nerve involvement, often with pupillary changes. And central causes such as multiple sclerosis or brainstem lesions may also produce weakness, but usually with additional neurological signs. Now, one of the most important aspects of managing our patients with myasthenia gravis is anticipating any deterioration before it becomes obvious, as patients can compensate remarkably well, especially early on. So a patient who appears comfortable at rest may already be close to respiratory compromise, and subtle signs such as a soft voice, an inability to count to 20 in one breath, or increasing reliance on accessory muscles should never be overlooked. There's also a rhythm to myasthenia that becomes apparent over time. Many patients describe a daily pattern where symptoms build as the day progresses. So understanding this can help tailor both assessment and treatment. So for example, examining a patient early in the morning may underestimate the severity of their condition. Similarly, timing their medications to coincide with the periods of greatest activity can significantly improve the patient quality of life. Another key consideration here is medication safety, because as we mentioned, a wide range of commonly prescribed drugs can exacerbate MG, and this includes certain antibiotics, cardiovascular drugs, and even magnesium. So in practice, this means every new prescription should prompt the question, could this worsen neuromuscular transmission? And the broader impact of the disease on patients' lives should always be remembered. Their fatigue isn't just physical, it's cumulative, and it affects daily functioning, employment, and mental health. And patients may adapt their behavior in ways that mask the severity of their symptoms, and so open-ended questioning with these patients is essential. Now, with prognosis here, we often say that life expectancy is near normal, but the lived experience of our patients can vary widely, as some patients achieve good symptom control with minimal medication, while others require long-term immunosuppression and experience recurrent exacerbations. Patients with an older age of onset and other comorbidities, including other associated autoimmune diseases, typically have a poorer prognosis. But what's changed dramatically over time is our ability to manage acute complications. So myasthenic crisis, for example, which was once associated with a very high mortality, is now far more survivable with modern intensive care and immunotherapy. And this shift reflects not just better treatments, but also earlier recognition and intervention. So just bringing everything together here now, myasthenia gravis is a disease that rewards careful observation and thoughtful management. It does challenge us to think dynamically. Symptoms change over time. Responses to treatment vary, and complications can arise very quickly. But with a solid understanding of the underlying physiology, a high index of suspicion, and a proactive approach to management, it's a condition where we can make a real and lasting difference. So that's a quick overview of myasthenia gravis, and I do hope you found the podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts. We really do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which take place all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.